Hi, welcome to POC Nurse. In this video, we're going to discuss sepsis and septic shock for the CCRN exam. Most hospitals in the United States have a protocol for treating and managing sepsis and septic shock. In the past, older medical studies stressed on the importance of things like CVP and SCVO2, central venous pressure, and central venous oxygen saturation. These days, there is more stress placed on fluid resuscitation, obtaining blood cultures in a timely manner, measuring serum lactate levels, and giving antibiotics as well as fluid resuscitation. And sometimes if vasopressors are necessary, they are given. So clearly, the management of sepsis and septic shock has changed over time and continues to change, I feel like, because the definitions of sepsis and septic shock have changed from 2001 to 2016, and we're going to discuss that shortly. Now, there are at least 1.7 million cases of sepsis in the United States involving adults and 270,000 deaths occurring per year. Sepsis is the number one cause of death in the non-coronary critical care setting, and the CDC states that 1 in 3 patients who die in the hospital have sepsis. Now, this number is supposed to increase because of the high incidence of sepsis in the older adult population. The current CCRN test expects us to understand sepsis and septic shock. Now, part of the old definition of sepsis and septic shock includes systemic inflammatory response syndrome and severe sepsis. They are not included in the new test because the definition of sepsis and septic shock changed in 2016. But we're going to touch on the old definitions and focus on the new definition and get some clarity as to why probably they changed the definition. Let's talk about systemic inflammatory response syndrome, SIRS. SIRS is a systemic inflammatory response to different kinds of clinical insults in the body, and it's manifested by either temperature of greater than or equal to 38 degrees Celsius, which is the same as 100.4 degrees Fahrenheit, or less than 36 degrees Celsius, which is about 96 point something degrees Fahrenheit. I have to check. And a heart rate of greater than 90 beats per minute, tachycardia, tachypnea, respiratory rate greater than 20 breaths per minute, or a PaCO2 of less than 32 millimeters of mercury. The normal is 35 to 45 millimeters of mercury, or a white blood cell count of greater than 12,000 or less than 4,000, or bands greater than 10% with a shift to the left. Now, a patient may have SIRS in the absence of sepsis. So, a patient could have a traumatic injury, burns, or pancreatitis and meet the criteria of SIRS. So, the criteria of SIRS is 2 or more of the things I just mentioned: the temperature, the heart rate, the respiratory rate, the white blood cells, or the bands. If a patient has 2 or more of those, they may be considered a patient with sepsis, right? So I think that's why they changed the definition of sepsis and septic shock, because a patient that has a traumatic injury is not a septic shock, but they are showing 1 or 2 of these SIRS criteria. Studies have also shown that this SIRS is a poor predictor of sepsis, and so the SIRS was removed from the new Sepsis 3 definition. What is sepsis? Sepsis is a life-threatening organ dysfunction that's caused by an abnormal host response to infection. So it's where the body is responding abnormally to an infection. In the initial phase, the infection may be suspected and not yet proven based on clinical examination of the patient and the patient's history. So where do we have a suspected infection? In the presence of positive blood cultures. If we culture the patient's urine, their sputum, or their blood, and it's positive for something. The patient may be suspected to have sepsis. If the patient is receiving antibiotics, antifungal, or some other anti-infective medication. If the patient is altered, especially in the elderly. If the patient has pneumonia on chest x-ray. If the patient is a nursing home patient with an indwelling Foley catheter. If the patient has a pressure ulcers, because wounds could be a source of infection. If the patient has an acute abdomen, or if there's immunosuppression going on, maybe this patient is on immunosuppressive medications. So when we talk about sepsis, we need to talk about infection plus organ dysfunction. To identify organ dysfunction, the patient is assessed using a Q-SOFA score or a SOFA score. Q-SOFA is Quick Sepsis-Related Organ Failure Assessment. So some examples of organ dysfunction involving the heart will be like hypertension. The lungs would be acute hypoxemia. If there's a drop in the patient's urine output, that could be a sign of organ dysfunction of the kidneys. If the patient has a lactate of 2 millimoles or greater, it could show organ dysfunction. If there's an abrupt mental status change, the patient just acutely becomes altered, is confused, lethargic, drowsy, that could be an example of organ dysfunction. This time we're talking neurologically. If the patient's platelets are below 100,000 and the patient is experiencing coagulopathy, these could be examples of organ dysfunction. Now to the Q-SOFA score. The Q-SOFA score is included in the Sepsis 3 definition, but it's not on the adult CCRN test for now. Maybe in the future it will be. The Q-SOFA score is a bedside assessment. There's no need for labs to identify patients who are suspected of having organ dysfunction. So there are 3 criteria for the Q-SOFA score, and each one has 1 point. The first one, in no particular order, is the systolic blood pressure when it is less than 100 millimeters of mercury. If the patient's respiratory rate is greater than 22 breaths per minute, so they're getting tachypneic. And if the patient's GCS, that is the Glasgow Coma Scale, is less than 15, 15 is the highest score. If it's less than 15, we may have altermentation going on. Now, a Q-SOFA score of 2 or 3 showed that there may be a good probability for organ dysfunction. So this is the Q-SOFA assessment for organ dysfunction. Now, we're going to talk about severe sepsis. Now, severe sepsis is not included on the new definition of sepsis and septic shock. This is from the old definition. So severe sepsis is when there is sepsis plus signs of organ dysfunction. Remember, severe sepsis is no longer technically being used in the definition of sepsis and septic shock. Severe sepsis is from the Sepsis 2 definition of 2001. It's still being used by Medicaid, but it's not included in the Sepsis 3 definition from 2016. Alright, we're going to talk about the difference between the Sepsis 2 definition and the Sepsis 3 definition to give us better clarity on these 2 definitions. So when we talk about SIRS, systemic inflammatory response syndrome, it's included in the Sepsis 2 definition, but it's not included in the current Sepsis 3 definition. When we talk about sepsis, in the Sepsis 2 definition, sepsis is the presence of an infection and a systemic response to the infection. So in the Sepsis 2 definition, we're talking about SIRS criteria and the presence of an infection. In the new Sepsis 3 definition, sepsis involves the presence of an infection and organ dysfunction. When we talk about severe sepsis from the Sepsis 2 definition, it is sepsis plus markers of organ dysfunction. There is no severe sepsis in the current Sepsis 3 definition. Talking about septic shock. Sepsis 2 and sepsis 3 definition of septic shock is the same. They both involve hypotension due to an infection. They both involve markers of hypoperfusion that persists even after adequate fluid resuscitation and necessitates the administration of presses. So in septic shock, there's hypotension. This hypotension is not responsive to adequate fluid resuscitation and requires the administration of presses. This is the difference between the sepsis 2 and sepsis 3 definition. Now let's talk about septic shock. More than 40% of hospital deaths are as a result of septic shock. Now, septic shock is a complication of sepsis, so it's clinically identified by the presence of an infection and requires vasopressors to maintain a MAP mean arterial pressure of greater than or equal to 65 millimeters of mercury even after giving adequate fluid resuscitation. It also involves a serum lactate of greater than 2 millimoles per liter, also even after giving adequate fluid resuscitation. What is the difference between infection, sepsis, and septic shock? Infection would have all the markers of the presence of an infection. The patient will have a white count, probably have a source of the infection, but the blood pressure is stable. The patient's blood pressure is stable. In sepsis, again, the patient has all the markers of an infection and probably organ dysfunction. The blood pressure is not stable, it is low. However, it is responsive to fluid resuscitation. So after you give the patient fluids, the patient goes from being hypotensive to normotensive. When we talk about septic shock, again, we have all the markers of infection. The patient is hypotensive, but even after giving enough fluid, the blood pressure does not go up. The patient remains hypotensive. Now, this patient will now require a vasopressor to bring their blood pressure up and maintain a mean arterial pressure of 65 millimeters of mercury or more. The main hallmark of sepsis and septic shock is diffuse vasodilation. In diffuse vasodilation, there's decreased systemic vascular resistance. SVR is low. Vascular volume is low. Anaerobic metabolism is occurring. In the late stage, cardiac output is low, and the patient may develop DIC or ARDS. What are some risk factors for sepsis? Extremes of age, chronic health problems, surgical wounds or any wound at all, invasive procedures and devices, urinary infections, patients that stay in the hospital for a prolonged amount of time, translocation of GI bacteria when the bacteria moves from the GI tract to other places in the body, acquired immunodeficiency syndrome when the patient is immunosuppressed, use of medications that are cytotoxic or immunosuppressive, patients that drink a lot, alcoholism, alcoholic patients or people, malignant neoplasms, cancer, bone marrow suppression, transplantation procedures, your kidney transplant, your liver transplant patients, and a history of a splenectomy. What are some signs and symptoms of early septic shock? So the symptoms for early septic shock are different for the symptoms of the later phase of septic shock, because in the initial phases, the body tries to compensate for that diffuse vasodilation to increase perfusion to the organs. So in the initial states of septic shock, in the early stages, you see the patient is tachycardic with a bounding pulse, so the heart is trying to pump blood faster around the body to increase perfusion and oxygen supply. Blood pressure is low but responsive to vasopressors at this point. The patient's skin is warm and flushed. Of course, the heart is pumping blood fast around the body. Respirations are deep and fast, so the patient is starting to get tachypneic. When the patient's lactate is measured, is greater than 2 millimoles per liter. Talking about the patient's mental status, the patient starts to get altered, especially the older people. Patients start to show things like confusion. Urine output drops, the patient starts to get oliguric, and the patient may have a fever with a temperature greater than 38 degrees Celsius or greater than 100 degrees Fahrenheit. In the later stages of shock, the patient's hypotension may not be responsive to vasopressors anymore. The patient is still tachycardic, but instead of the pulse bounding, it is now weak and thready. When we take the patient's lactate measurement again, it is now 4 millimoles per liter or higher. Where the patient's skin was warm and flushed in the initial phases, the patient's skin in the later phases becomes cool and pale. So in the earlier phase, the patient is warm and flushed, and in the later phases of septic shock, the patient's skin is cool and pale. The patient's respirations may be fast or they may be slow. When we talk about the patient's mental status, they could be lethargic at this point or slip into a coma. The patient's urine output may become non-existent at this point. The patient may get anuric, whereas in the earlier phases, the patient was oliguric. Patient may become hypothermic with a temperature less than 36 degrees centigrade or less than 96.8 degrees Fahrenheit. Septic shock comes with some hemodynamic alterations. In the early phase, cardiac output or cardiac index goes up. The patient's right atrial pressure goes down. Also, the patient's PAOP, pulmonary artery occlusive pressure, goes down. Systemic vascular resistance goes down. It is low. SvO2 is high. Oxygen delivery is high. However, oxygen consumption is low. In the later stages of septic shock, hemodynamically, cardiac output and cardiac index is low. Right atrial pressure, pulmonary artery occlusive pressures are high. Systemic vascular resistance is supposed to be the hallmark of septic shock. It's supposed to be low because remember we talked about diffuse vasodilation. But one book I read said SVR would be variable. The other book I read said SVR would be low. If you are looking at the test question, I would go with SVR being low for septic shock. Because remember, the hallmark of septic shock is diffuse vasodilation. SvO2 is variable in the later phases of septic shock. Oxygen delivery is low and oxygen consumption is still low. Let's talk about some lab values that may indicate septic shock. In the early phases, the patient's troponin may be elevated, lactate is elevated, glucose elevated, bands elevated. Some lab results could indicate septic shock. Some of these labs are troponin. In the early stages of septic shock, troponin could be elevated, lactate elevated, glucose elevated, bands elevated. The patient may or may not have a high white count, so the patient's white count could be high or low. The patient's platelets could be low. The patient's PT/PTT could be high. When you do your ABG on the patient in the early phase, it could show up as respiratory alkalosis. There could be a mild decrease in the PaO2, or patient may have combined respiratory alkalosis and metabolic acidosis. During the late stage of septic shock, the progressive stage, the patient's ABGs show metabolic acidosis and there will be severe decrease in PaO2. The patient's PT/PTT will be severely elevated, platelets severely low, the patient's white blood cells will be low, the patients will have very high bands, glucose will be low, the patient's BUN and creatinine will be elevated at this time because the kidneys are most likely shutting down. Patient's liver enzymes will be elevated, lactate will be elevated, and troponin will be elevated. Blood cultures are usually done when the patient is presenting with suspected sepsis or septic shock, but only 30 to 50% of patients that present with sepsis or septic shock will have positive blood cultures. What is the treatment for sepsis or septic shock? Like we talked about before, all if not most hospitals usually have a protocol for treating or managing sepsis or septic shock. It usually involves giving the patient fluid. A fluid challenge at 30 ml per kilograms of crystalloid is given as early as possible, and this is done so that we can achieve a MAP of greater than or equal to 65 millimeters of mercury, or maintain a urine output of 0.5 milliliters per kilogram per hour, and to also decrease tachycardia. If the hypotension is not responsive to fluid resuscitation, that is, after giving fluid the patient is still hypotensive, then vasopressors are started. The first choice for vasopressors is norepinephrine, also known as Levophed. If Levophed is not enough to maintain a MAP of 65 or higher, a second vasopressor can be added, and according to CCRN, epinephrine is the recommended second vasopressor that can be added. If the patient's blood pressure does not respond to the high dose of vasopressors and fluids, then the patient may have catecholamine refractory septic shock, where the alpha receptors in the arterial beds are not responding to the vasopressors. In this case, a vasopressin drip can be started. Vasopressin is usually not titrated. It's usually at a fixed dose of either 0.03 units per minute or 0.04 units per minute. And it's not a first-line agent for treating hypotension related to sepsis and septic shock. It is used to enhance the effectiveness of the initial pressors that were started to treat septic shock. Now, if the vasopressin is not effective either, the patient may be in extreme metabolic acidosis where no matter what you give, it's not going to work, or the patient may be in corticosteroid insufficiency that is related to being critically ill. So in this case, you would give sodium bicarbonate or give steroids. Either way, neither of these measures have shown that they can improve mortality rates. Another thing to do in the patients that have sepsis or septic shock or presenting with sepsis or septic shock is to draw 2 blood cultures as early as possible from 2 different sites before antibiotic is given. Also, the patients should start to receive broad-spectrum antibiotic therapy as early as possible once sepsis or septic shock is recognized and after the blood cultures are drawn. So it makes sense to give the antibiotic, to draw the blood cultures before you give the antibiotics, so you're able to catch the culprit, whatever is causing the patient to be in sepsis or septic shock. So after the blood cultures are drawn, broad spectrum antibiotic therapy should be started as quickly as possible. Preferably, the antibiotics should be started within an hour of the recognition of the patient being in sepsis or septic shock. A study was done on the times within which the antibiotic was given in sepsis or septic shock, and it showed that for every hour that the antibiotic was delayed, there was an approximate 12% decrease in the patient's probability of survival. Also, it's important to, or part of the sepsis or septic shock management calls for obtaining lactate levels as early as possible. So we draw the first lactate, and if it is greater than 2 millimoles per liter, then we know something is going on. So within 2 to 4 hours, we draw another lactate. So we trend the patient's lactate to see if it's trending up, going up, or trending down, going down. Also, the source of infection needs to be identified as soon as possible. so that it could be treated. I once had a patient, actually a young patient, but diabetic, chronic diabetic, that had a wound on one foot or both feet that was making her septic. She was on vasopressors. So that night, I work in it was a big hospital. So that night they took her to the OR. They braided that wound. I think it was on her toe or something. It had to be amputated. She got better and she was downgraded from critical care status to PCU or something else, but she did get better. So it's important as part of sepsis/septic shock management to find the source of the infection and treat it, whether it needs to be surgically treated, a line needs to be removed, a Foley catheter needs to be discontinued. It's important to find the source and address it. Also, if the patient's MAP remains below 65 millimeters of mercury, or the patient's lactate is 4 or higher, it's important to reassess the patient's fluid status. So a licensed independent practitioner would conduct a focused clinical assessment on the patient, or they could assess CVP, assess the patient's fluid responsiveness with a passive leg raise or a fluid challenge, or do a bedside echo, or measure the patient's central venous oxygenation. So the licensed independent practitioner could do any of these two. Inotropic therapy can also be used in sepsis or septic shock. Dobutamine is usually recommended by itself or in addition to vasopressin. That is for patients with cardiac dysfunction. So if the patient's CVP is high and the patient's cardiac output is low, or the patient has clinical signs and symptoms of low perfusion, after successfully restoring the patient's blood pressure with effective volume resuscitation, and all of this is not working, then dobutamine can be started. So inotropic therapies for those patients with sepsis and septic shock that have cardiac dysfunction. Oxygenation goals for septic shock include maintaining an O2 sat of 95% or greater, a central venous oxygen saturation of greater than 70%, or a mixed venous oxygen saturation of greater than or equal to 65% when the CVP and MAP goals are met. If these goals are not achieved, meaning if the central venous oxygen saturation or mixed venous oxygen saturation goals are not met, then further fluids may be given, a dobutamine infusion may be started, or the patient may be transfused with PRBCs if the patient's hemoglobin is 7 or less. To conclude, we talked about what sepsis and septic shock is. We talked about the new definition of sepsis and septic shock, which includes a source of infection and organ dysfunction in terms of sepsis, and then in terms of septic shock, we talked about the patient needing vasopressors, amongst other things. The therapeutic goals for septic shock are: 1, to increase the patient's MAP to 65 millimeters of mercury or greater, to decrease the patient's lactate level, and to improve the patient's base deficit, to also normalize the patient's heart rate. They're usually tachycardic. We want to bring the heart rate down. We want to increase the patient's urine output to 0.5 milliliters per kilogram per hour or greater. We want the patient's extremities to be warm. The patient's mental status needs to return to baseline. And of course, control the source of infection. So if it is an infected central line, remove it. If it's an infected Foley catheter that's causing it, remove it. If it's a wound that's causing it and that wound can be surgically removed, remove it surgically. Another therapeutic goal for septic shock is to normalize the patient's CVP to 8 to 12 millimeters of mercury, and for the central venous oxygen saturation to be 70% or higher, or the mixed venous oxygen saturation to be 65% or higher. This is where we're going to stop for sepsis and septic shock. I hope you found it helpful. Please like, share, and subscribe, and I'll see you in the next video. Bye bye now. Thanks for watching.